Effective renal plasma flow, or ERPF, is the amount of plasma flowing through the kidneys per unit time. It's estimated using the PAH clearance. Now, PAH is both filtered and actively secreted into the proximal tubule. Because almost all of the PAH that enters the kidney through the renal artery will be excreted, we know that the PAH concentration in the renal vein will be near zero. Therefore, knowing the clearance of PAH gives us a good estimate of the total plasma flow through the kidneys. Renal blood flow can be calculated by dividing the renal plasma flow by 1 minus hematocrit. The 1 minus hematocrit is the percentage of volume flowing through the kidneys that is plasma. Thus, renal blood flow is a measure of the total blood flow, including both plasma and cell mass. So here's a question related to renal blood flow that will be useful for you to remember. How much of the resting cardiac output do the kidneys receive? Kidneys receive about 25% of the resting cardiac output. This is typically 1.2 liters per minute. Filtration fraction is the fraction of plasma going through the kidneys that gets filtered, meaning it passes from the glomerulus into Bowman's space. It is calculated by dividing the GFR by the RPF. Do you know what percent of plasma that's normally filtered? Well, it's normally about 20%, but it can be altered, either with natural hormones or with drugs. For example, angiotensin II preferentially constricts which arteriole? Correct, the efferent arteriole. Now, how will this affect renal plasma flow? Well, it will decrease the RPF. If you block flow from the efferent arteriole, there will be a backup of plasma flowing through the kidneys. However, angiotensin II also leads to an increase in the GFR by increasing the hydrostatic pressure gradient. So the FF, or filtration fraction, will ultimately increase. On the other hand, prostaglandins can affect the filtration fraction in a different manner. Prostaglandins dilate which arteriole? Correct, the afferent arteriole. This will lead to an increase in both the renal plasma flow and GFR. Therefore, the filtration fraction will thus remain unchanged. Now, let's continue our studies of filtration fraction by working through some changes in glomerular dynamics. To understand these changes, you'll have to know how blood flow through the arterioles affects filtration through the glomerulus. Constriction of the afferent arteriole will decrease renal plasma flow and decrease the GFR because there will be less pressure in the glomerulus. So what do you think will be the change in filtration fraction? Well, if they both decrease, there will be no change in filtration fraction. Constriction of the efferent arteriole will decrease renal plasma flow, but increase GFR due to the increased hydrostatic pressure. What will this do to the filtration fraction? Well, it'll increase it. What will increasing the plasma protein concentration have on renal plasma flow? There'll be no change. GFR will decrease because there'll be increased oncotic pressure in the glomerulus. However, GFR will decrease because there will be an increased oncotic pressure inside the glomerular capillaries. The oncotic pressure given by the proteins will want to pull more fluid into the capillaries and decrease the GFR. This will lead to what change in filtration fraction? It will decrease. Now, decreasing the plasma protein concentration will also have no effect on renal plasma flow, but it will increase GFR. This is because there will be less oncotic pressure inside the glomerular capillaries. Now, what will this do to filtration fraction? You guessed it, it'll increase. Finally, constriction of the ureters will have no effect on renal plasma flow. What will it do to the GFR? Well, it'll decrease it. Urine will not be able to flow from the kidneys to the bladder, eventually causing a backup of the hydrostatic pressure. Therefore, filtration fraction will also decrease. Now, let's try some example questions. Will the filtration fraction of a patient in the early stages of shock be higher or lower compared to a normal filtration fraction? Answer: higher. Now, this is a tough one. When people are in shock, they aren't getting enough blood to their vital organs. In the kidneys, this means that the renal plasma flow will be low. The body responds by selectively vasodilating the afferent arteriole while vasoconstricting the efferent arteriole. This has the effect of increasing the net hydrostatic pressure gradient, which in turn raises the GFR. Since the renal plasma flow is decreased but GFR is increased, the filtration fraction will be higher than normal in a patient with shock. Look for these types of situations on your exam because the USMLE likes for you to think through multiple steps. To understand reabsorption and secretion, we have to compare how much of a substance is filtered versus how much of it is excreted. The filtered amount equals the GFR times the plasma concentration. The excreted amount equals the urine flow rate times the urine concentration. If the filtered amount is greater than the excreted amount, then the substance is being reabsorbed by the tubules. If the excreted amount is greater than the filtered amount, then what do you think the nephron is doing to the substance? Well, it's secreting it. This is the same concept we talked about when we compared GFR and clearance of a certain substance. If reabsorption is taking place, less of the substance will appear in the urine. Normally, glucose is freely filtered through the glomerulus, but is completely reabsorbed in the proximal convoluted tubule. However, if the plasma concentration of glucose gets high enough, the glucose transporter becomes saturated and can no longer reabsorb all of the glucose, and some of it remains in the urine. Do you know at what level of plasma glucose you'll begin to see glucose in the urine? Around 200. The transporters are fully saturated at about 375. Now this is a key problem with what disease discussed during the endocrinology section. That's right, diabetes. The elevated plasma glucose eventually leads to increased level of glucose in the urine, which causes an increased amount of fluid in the urine and increased urination. This process is called osmotic diuresis and is one of the hallmarks of diabetes. The second important substance that must be reabsorbed is amino acids. Normally, these are small enough to be freely filtered through the glomerulus, but then they are completely reabsorbed by a sodium-dependent transport mechanism. Any idea where else we might see this example of sodium-dependent transport? In the enterocytes during carbohydrate absorption. Glucose and galactose are taken up by the SGLT1 sodium-dependent transport mechanism in the gut, a process very similar to the amino acid reabsorption in the kidney. There really shouldn't ever be amino acids detected in the urine, and if there are, it's a sign that there might be some genetic deficiency in amino acid reabsorption. If you can remember from biochem, Hartnupp's disease is the result of a deficiency in a neutral amino acid transporter. This leads to an inability to reabsorb which amino acid? Tryptophan. And since tryptophan is a precursor for niacin, this results in pellagra, a disease of niacin deficiency. On the exam, a pellagra patient may present with symptoms of erythematous skin lesions, diarrhea, and dementia, and a helpful test to diagnose this patient would be to check the urine for tryptophan. You can remember this with the 3 Ds mnemonic: diarrhea, dementia, dermatitis. Flash quiz. What is the formula for estimating what metabolic derangement will they have? Metabolic alkalosis, because they're also losing a bunch of hydrogen ions too. Do you know what this syndrome is called? This is called primary hyperaldosteronism, or Conn's syndrome. Now, only about 5% of the sodium is actually reabsorbed here. So, diuretics that act at the collecting tubule do not have a very strong diuretic effect. Now, only about 5% of the sodium is reabsorbed here. So, diuretics that act at the collecting tubule don't really have a very strong diuretic effect. This physiology is important. So as you move forward with your studying, look back to this section in your book to refresh your memory about the function of the nephron. It's really important to know for the exam, and it'll make you shine in your clinical rotations as well. Flash quiz. What is the class of medication that both decreases sodium reabsorption in the nephron and inhibits aldosterone secretion? Answer: ACE inhibitors. With the prevention of angiotensin II production, more sodium will be lost in the urine, leading to more water diuresis as well. Secondly, without angiotensin II, there's no stimulus for aldosterone release, leading to increased sodium and water loss and a decrease in blood pressure.